Couple of great cases, as always, and as a reminder, this information is protected with under the law for HIPAA, so information that we present here is confidential and privileged, and that it is prohibited for you to copy it or distribute it, and honestly talk to anybody outside of our line of work about the details. So for case one, we have a 50-year-old female. EMS were dispatched to a breathing problem, and the patient was complaining of shortness of breath and tremor. Uh, During their primary assessment, they found the patient to be awake. Her airway was open and she was protecting. Her lung sounds were documented as no abnormalities, assuming that that probably is no wheezing and no bronchi, and that they documented in their chart that she had 2+ radial pulses, no mention to skin temperature or moisture. So just a 2+ radial pulse. They obtained vital signs 2 minutes after patient contact with a heart rate of 80, blood pressure 192/102, respiratory rate recorded at 30, and SpO2 of 99. The past medical history that they included is cholecystectomy, although I would probably say more surgical history. And then the meds that they reported was meclizine, although they also had a section that said none reported under meds too, but I think that was probably an error in Zofran. And then I just added her allergies as it's pertinent to this presentation complaint, Keplex and sulfa. The HPI that they documented was that she was concerned she may be having a reaction to her prescription antiemetics or dizziness meds. Although that she did report to them, she had no other complaints. So pertinent negatives were no chest pain, no hives, no abdominal pain, no nausea, no vomiting, no headache, no dizziness, no vision changes or weakness reported. This call occurred in the afternoon at 12:50. The vital signs, as I had previously reported, they got a subsequent blood pressure a minute after the last one, which was worse than the previous at 210/100. They documented that she was in moderate distress when they made contact with her, and that the patient had reported anxiety with meds, and that she indeed even took half of her normal prescription strength that she was instructed to do so because of her anxiety in the past. She reported to EMS that she thought her symptoms were related to anxiety, and that since either they arrived or prior to their arrival, her symptoms had resolved, and that she was declining transport, treatment, and evaluation. They did do another set of vital signs, or at least partial vital signs, approximately 5 minutes after the first full set. They documented that her respiratory rate had improved to 20, and then they reported a blood glucose of 110. At 13:01, she signed her refusal form. In their narrative, they documented that no further harm could result without medical treatment or evaluation. And then they cleared the scene at 13:13. There is no Pulsera as she wasn't transported. And then in reviewing this case, this was brought up as our monthly refusal case to review. In reviewing it, they did get a full set of vital signs, although she never had an improvement in her blood pressure, and that we document that it was getting worse. They did re-document that she had an improvement in her oxygen, her respiratory rate from 30 to 20. And they documented that a refusal form was completed. Her areas for improvement that was brought up was her primary impression. Is there anything else that you would add, Dr. Mock or Mark, or really anybody in the call?
No, I think go ahead and finish, and I'll have a little bit of a discussion at the end.
Okay. So I looked her up to see if she had presented to the emergency room that day or any time in the future from that day that she presented, and at least through Peace Health, she hadn't. And so we brought this case up. Dr. Mock may want to talk more about the documentation of her primary chief complaint, which they documented as anxiety. Did you want to bring up any other points? He pulled a table from our data on refusals and noted that the top 10 primary impressions among refusals are as follows. And you can see the most common complaint that is documented for the patient is anxiety or emotional upset.
Yeah, so no, thank you for bringing this case. I know this is not a super exciting case. Wanted to make a couple of points. One, it's always easy for us to kind of look smart when we have all the information in retrospect and say like, well, this is how this case turned out. But I wanted to use this case to kind of talk about ways that we can make our practice safer. And and one way that you can demonstrate kind of the thought process that you put into evaluating this patient is in the primary impression. And one of the things that's in our documentation guide is that we want you to talk about the worst, worst first, the worst possible primary impression should be what you're putting there. So if the patient complained of chest pain and anxiety, then the primary impression should be chest pain. If the patient complained of palpitations and anxiety, then the primary impression should be palpitations. And so Dr. Gadbois brought this up, and so here's and like this is kind of what our data looks like. And then as you look through these cases, like for example, this 82-year-old male who had a primary impression of anxiety reaction and emotional upset, you look at the chart and he said he was complaining of heart problems. And so we value your ability to think through the case and using a primary impression that reflects the worst possible diagnosis or the worst possible impression for the patient's complaint is a way that you can clearly show that you've thought through the case and been cautious. I welcome any questions about that, but that was my only goal in bringing this case up.
I think I think these are solid points. I mean, even in my own clinical practice, I do not document anxiety for the patient. I'll document as their primary impression whatever they were complaining about, even if there's a concern that there was indeed an anxious component to it. And that's because for me, I don't want for this chart to be reevaluated and that I am perceived to have blown this person off and that they end up actually having something that was catastrophic or pretty significant. And I think that when when we review our own charts or when another outside person, third party reviews our charts and we document the primary impression as anxiety, there's a lot of disgust, I think, when people are like, even the patients for us in the hospital system, they review our charts as well as they have access to look at them and they get equally feel the same type of disdain about, well, you didn't take my condition real or that this actually was a problem and you just documented or you just perceived me as just being an anxious person. So um, personally, I don't document anxiety as a chief complaint as a diagnosis in my charting.
Yeah, I think I agree with everything you said, and the last thing I'll add to that is, I may use it if that is the patient's only chief complaint. There are no physical symptoms, but as an example, over the weekend I took care of a 36-year-old guy who, was complaining. He had carpal spasms. He was breathing fast. He had a heart rate of 130. He was complaining of chest pain and and after two troponins, the CT of the chest, a blood gas showing a respiratory alkalosis. At that point, I was willing to call it hyperventilation syndrome because I had objective evidence to document that. But even at that point, I wouldn't give the diagnosis of anxiety to someone with that chief complaint. So that's I think we've uh, I think we've made the point. I welcome any questions. And again, it's about making our practice as safe as it can be for our patients. Um, no, and
Right.
the last thing I see the
comment?
In the chat. No, we as a county select which primary impressions are available in ESO. Same for us as doctors. We can't just make up our own diagnosis. We have to pick from a list. But even in ESOs, what I'm talking about are, selecting diagnoses in ESO that reflect the worst possible thing that could happen. So if it's if a patient complained of chest pain and anxiety, chest pain. If they complain of shortness of breath and anxiety, shortness of breath, and those are all primary impressions that are available in ESO.
Thank you. Sure what happened here. Can you guys see my screen again or no?
Yes, we can see your screen.
Yeah.
Okay, the Clark County refusal data. Okay, great. So I'm just gonna, I know it's a really busy slide, and this is our patient refusing care slide. I think in an effort to be succinct here, I'll talk about what type of situation necessitates a call to online medical control and what doesn't. And then I'll talk a little bit about why it's important to be able to go down and categorize your patients properly. So, as all situations, we need to determine if they have decision-making capabilities in the event that we can make sure that ultimately that the patient should have informed consent or informed decision-making, and that if the patient doesn't, um, that kind of breaks this down for our protocol. So if the patient has, let's talk about if they do have capacity for decision-making and having informed consent. If there's no medical need exists for this patient, then a refusal form is not necessary, and we need to document that in our chart properly. And the disposition is patient evaluated, no treatment transport required. If transport is not necessary, but they do have a potential medical issue that doesn't require something for us to do in the pre-hospital setting, if that's like spinal mobilization or telemetry or serial vital signs or EKGs, potentially serial EKGs, then these are people that like kind of think of it as they may have stubbed their finger, or that they have abrasions, or they have a cough and they, want to be checked out or want to go to the hospital. So these are kind of things that you don't foresee that you're doing anything that they can do in their own private vehicle. So non-emergent medical need exists if transport's recommended by the EMT. Refusal form and an EHR must be completed by the EMT or the paramedic attending to the patient. If transport's not required by EMT, complete EHR with all the necessary elements. Explain the decision making that the patient has the capability of doing, and then give callback precautions and have the patient sign it. The disposition should be patient treated release per protocol. There are a few times that we have crisis standards, but we're not going to be talking about that right this moment. And then the next section under C, if you're following along, is that immediate medical care and or ambulance transport is necessary. So a refusal form is necessary. Every effort should be made. And I want you to, for those that are very systematic in regards to our protocol, every effort should be made with number one, soliciting family or friends or close associates, and number two, potentially law enforcement. If those are unsuccessful, then it's the recommendation to consult medical control. And I say that because oftentimes when I take a call for medical control, nobody else has talked to the patient besides the paramedic. So oftentimes it can be very convincing for people that they care about or that care about them to convince the patient, and that would potentially save you from calling online medical control. This is a patient that was impressionable enough to change their disposition plan just by talking to the people around them. But if you're still unsuccessful with having those close to them or law enforcement change their their feelings about transport, online medical controls, mandatory, and that the purpose of medical control is to influence the patient to agree to transport or treatment. Um, and then your documentation should include all the necessary elements, and it should be categorized as patient treated, released against medical advice, refusal. The reasons why it's really important for us to determine who actually needs an online medical control call. I don't know the numbers. Maybe Dr. Mott can speak to it, but I would believe that there are plenty of patients that call 911 and you guys go out to them and they may have no medical problem or they have a medical problem, but it's not anything that needs to go by emergent transport. And if we call for every single person that has a medical problem that doesn't require transport, that's a lot of phone calls to online medical control who are already fielding other complaints that in within the department, but also that other of your colleagues are calling in, if that be medical um, pronouncements, medical consults, refusals, whatnot. So if you, and I've gotten some feedback from your colleagues already saying that it can take a long time before they actually get a hold of any doc on their online medical control calls. So we really want to be judicious about how we determine which refusals require online medical control. And if you're ever in doubt, you're always welcome to call online medical control. But I also think that I've talked to some people that have mentioned that they're new and they just don't know who needs an online medical control call. And if it's a matter of that you're not quite familiar with your protocol or that it's kind of a gray area, another option is to contact your on call or your on duty supervisor, if that be for AMR or for your fire service. Um, I think that's all I'll cover on this page of protocols. Is there anything that anybody else wants to add or to clarify?
No, I'll just add that we're also working on a ring down system to make it easier to reach medical control when you need it, and we'll update you when that's ready.
Some, if no one has any other questions about case one, we'll move on to case two. This is of a 58-year-old male who was mowing the lawn. Um, the call came out as chest pain. The patient was found to be unresponsive. His area was open, but he was tachypnic. He was noted to be pale, diaphoretic with a thready pulse and no active bleeding. Vital signs were obtained 4 minutes after patient contact. Noted to have a borderline heart rate of 60, a soft blood pressure, or a borderline blood pressure of 90 over 58. I mean, I guess you could probably just call it hypotension. And then tachypnea at 26, no room air sat was documented. The past medical history was provided by the patient's wife, who had indicated that he was recently diagnosed with a cardiac condition and they were planning on intervening, but the details were not available through the wife. Meds were none were reported, probably from the acuity of the patient, and that um, the patient was mowing the lawn that day and came inside and collapsed, and prior to collapsing was complaining of chest pain. This call occurred late morning. The initial vital signs is what I had previously reported. They had him on 3 liters nasal cannula. At 11:31, an IV was established. At 11:32, another set of vital signs minus the heart rate were obtained, noted to be largely unchanged, but the SpO2 was documented at 90% this time, and a 12 lead was obtained. So, as a reminder, 12 lead was obtained 6 minutes after patient contact. This 12 lead shows marked abnormalities. Although there's some artifact, overall, I think the quality is good enough to be able to call it what it is. Looking at this EKG, you see there's a lot of irregularity, but underlying this looks like this is the patient's underlying rhythm. And you can see there's ST elevation in 1 and ABL. As you look for reciprocal changes, you see some potentially in 3 and ABF, not so much in lead 2. And then as you go over to the precordial leads, you see that he has ST elevation in V2, V3, V4, and V5, consistent with anterolateral changes as well. Or um, so, and then there's some ectopy. So he would be a patient that meets criteria for STEMI activation. Another 12 lead was obtained 3 minutes after the previous one. And although it's a little bit better for tracing, less artifact, it shows the same ST elevation, meeting criteria for STEMI activation. So, 14 minutes after patient contact, transport was initiated. He has a heart rate of 69, a blood pressure of 90/58, and his SpO2 is recorded now as 97%. His glucose is normal at 103, and he's received a full dose of aspirin. Assuming that he's coming around a little bit at this point, as the initial documentation was that he was unconscious. So we wouldn't be giving aspirin to somebody who couldn't chew. At 11:44, at the time that they arrived to the hospital, they document a heart rate of 130, no repeat blood pressure, and SATs of 96%. In Pulsera, the only notes, which I think are pretty clear, the only notes they have is a STEMI alert inferior. They don't document anything in regards to if the patient is awake or if the patient has any assistance with breathing, but just the STEMI inferior. They did report vital signs in the Pulsar report. So they document a heart rate of 90 and a better blood pressure than what was reported really at any point. So it might have been a typo with a 98/58, and a GCS of 5, which your charge nurse that's taking this call would ask, is this patient intubated? They asked for an EKG, and ultimately, the response back was, we're arriving, elevations were reciprocal on right side. So there was no EKG, and when there's no EKG, our criteria for Peace Health is that we cannot activate it as a STEMI alert until the 12 lead has been reviewed by the ER doc. So this patient did not get activation until he had a 12 lead done in the emergency room. So they document first contact, but I would say that their documentation in Pulsera at 11:39 isn't quite the same as reality for what we document at 11:26. But I think that that's the best that they can do based off of when the Pulsera has been initiated. And I just put in some of the times that, or I put in a screenshot of the times that Pulsera reports. So when the Pulsera account was created, the case, when the hospital acknowledged it, um, when the patient actually arrived, and when the patient actually had STEMI activation at that time. And this is also in your Pulsera cases when you bring in STEMIs, they talk about the intervention times as a reminder of what our goals are. I don't think that the EMS patient to ED arrival is always accurate based off of what Pulsera documents, but our goal is to get them as quickly to the hospital as possible, and arrival to device is 90-minute goal. So ultimately, so I'll tell you about the patient outcome here, which we'll talk about. Was there any huge detriment in this case or not? So the good rapid obtainment of 12 lead and vital signs, IV access, SpO2 recorded, aspirin given if the patient meets the criteria, serial vital signs, and a scene time of less than 20 minutes. And the reason why I put scene time in here is because our KPI goals for STEMI are less than 20 minutes scene time. And then areas for improvement, STEMI activation criteria. As a reminder, again, we cannot activate in the pre-hospital setting cases until we see a 12 lead confirmed by an ER doc. And I don't know what the criteria is at Legacy. Maybe Dr. Mott can also confirm if that's the case for you guys. But if we don't get a 12 lead, we can't activate until we have one.
Yeah, the cardiologists at Legacy have said they might consider, but in general, the thing that this patient needs is to have a stent. The thing that gets the team in motion to get the stent is sending the EKG. I mean, the times are close on this one, and so I understand their competing priorities. But just not like the sooner you send the 12 lead, the sooner you activate the team, the sooner the patient gets the stent.
Absolutely. And then for us, as soon as we activate either either from pre-hospital activation or hospital activation is that the team has 30 minutes to arrive to bedside. So, um, if you have a patient that you identify having a STEMI at um, 11:32, then that means that there wouldn't be a 14-minute delay to get the team in gear um, when they actually activated at 11:46. So, in the emergency room, the patient's initial vital signs, heart rate of 168, blood pressure 102/87, respirators of 21, and SATs of 94%. They get a 12 lead. It's interpreted as wide, complex, irregular concern for atrial fibrillation with rapid ventricular response. Did not felt to be VTAC. The patient had pulses with this. The ER doc had consulted cardiology emergently based off of the pre-hospital 12 lead that they looked at. So they never got a 12 lead that showed a STEMI because they have an EKG that shows AFib, but based off of the pre-hospital EKG that they were able to see, and then also this patient's AFib with RVR and their presenting presentation, basically, they talked to cards and they um, discussed potentially cardioverting this patient or taking him to the cath lab. And given the pre-hospital 12 lead, they decided to take the patient to emergently to the cath lab. Um, the patient received some blood thinning medications in the emergency room prior to going to the cath lab. In the cath lab, they noted that the patient had 100% occlusion to the left anterior descending, in which the patient had received 2 stents. The patient developed cardiogenic shock and hypotension following an Impella was placed. The patient was going into respiratory failure because of their cardiogenic shock. They induced the patient with meds for RSI, but he arrested with the induction meds, and they continued CPR for about 4 minutes before getting Ross back. Once they got Ross back, they emergently discussed a case with cardiothoracic surgery because of his worsening hypotension and cardiogenic shock that was refractory to pressors. So the cardiothoracic surgeon came to the cath lab and cannulated him for ECMO and transferred him to the VA Medical Center OHSU site. I think the VA ECMO is just who is performing, but the patient went to OHSU. The patient was admitted for 30 days at OHSU with the principal diagnosis of cardiogenic shock and the secondary diagnoses of anterior STEMI, paroxysmal AFib with RVR, which he had another episode during his month-long stay. He had an injury to his right femoral artery from cannulation, and he had thrombus to his vessels. He also suffered a stroke after he was resuscitated, initially arriving to OHSU. They extubated him. They found that he was a little drowsy, thought that it was potentially related to metabolic causes, and then he was having difficulty with talking and swallowing. So they did a MRI and noted that he had multiple embolic stroke, probably from his resuscitation about for his intervention in the cath lab. He also developed pneumonia and an acute kidney injury and some urinary retention, but ultimately was able to be discharged. So in this particular case, I don't believe that the potential for what I say 14-minute delay made a big difference, but there are definitely going to be cases that that 14 minutes is going to make a big difference. So 14 minutes of like getting so let me be clear, the 14 minutes is based off of the initial 12 lead to notify the hospital. I don't think that our practice right now is to notify the hospital, notify through Pulsera that we have a STEMI activation based off of the first 12 lead. And if that's incorrect, please let me know. But what I do think happens is that we tend to do the Pulsera either as we're loading the patient up or we're transporting. And at that point, it's really important to make sure that what you want the hospital to receive you as is being met, and that requires a 12 lead EKG.
Yeah, no, it just as soon as you have a 12 lead showing STEMI, it makes sense to send it and that pull to the cath lab for your patient. And that'll keep, that means that if another crew heads en route or a transfer, other things that could potentially use the cath lab, um, the cath lab is held for your patient once the STEMI team is activated.
Yeah, absolutely. So based off of this particular case, this case was brought to our attention from the STEMI meetings about a delay because of a lack of a 12 lead. And I also recognize that, oftentimes we get a 12 lead in and the patient's appropriately activated, and sometimes they aren't activated because the ER doc, for whatever reason, doesn't feel like the 12 lead it meets criteria. And we're working on trying to do some education for those docs that should have called a 12 lead a STEMI from the pre-hospital setting. But anyways, so I'm not sure about your guys' experience with with the guidelines and what goals we're trying to do. Initially, I was looking in, you know, kind of communicating about fibrinolytics and patient to device standards, but it got me down this pathway of what AHA guidelines are for management of STEMI, although this is from 2004 and I didn't find anything that was more recent than that. So to explain the level of recommendation, the level A to D is based off of how reliable the data is backing this goal. So level A data is pretty well documented that they're usually associated with randomized controlled trials. And level B data is pretty good evidence that it's recommended. I'd say pretty good, as in like most of the time we're looking at level B or level A data when we're making decisions on how reliable that information is. So level B is that this information comes from case control or cohort studies. And then level C data is that it's from either a low quality cohort study or case control study. And then level D data is it's an expert opinion, but there isn't a lot of research that backs it. So it doesn't mean that it's bad. It just means that we don't have a lot of support with it. So hopefully that explains the level A, B, C, D data. And there's no data here that's D. So um, level A recommendations are for early defibrillation in the pre-hospital setting, particularly aspirin is recommended, but not super strong evidence, which I found kind of interesting myself, as I feel like we oftentimes teach to it's the one thing that can help until you get to the patient to the cath lab. But either way, level B that we should be getting a 12 lead. There's, I think it was up to 15 minutes after patient contact, but our goal in the county is for 10 minutes. There's some evidence to support reperfusion checklists. I didn't go into a deeper dive on what that looked like. I don't believe that we have any reperfusion checklists, and that a patient should go to a PCI center whenever possible, which is level A support. And if a 12 is obtained, it should be and this is more towards the hospital setting. So this was all pre-hospital for the first 5 bullet points, and the last two major ones are hospital related. So a 12 lead should be interpreted by an ER physician or an equivalent within 10 minutes. And if the initial 12 lead is non-diagnostic, but the stories is really good for cardiac etiology, the recommendations are to repeat every 5 to 10 minutes. So kind of further supporting when we talk about getting serial EKGs for patients in the pre-hospital setting, we also do that in the hospital setting. Um, from patient contact, so that's when we take our patients from the pre-hospital setting. That's the time when we make contact with the patient to they not only go to the cath lab, not only get intervened, but the time from when the balloon is inflated, our goal is to be less than 90 minutes. So really, the 90 minutes seems like a lot, but as you can think about, if we're spending 20 to 30 minutes on scene, we're taking 20 to 30 minutes in the ER potentially or longer, and there's any complications with getting them to the cath lab or getting them cannulated, that 90 minutes really starts to come up pretty quickly. And then if we can't get them to a PCI center within 90 minutes for patient contact to balloon inflation, the goal is to start fibrinolytics within 30 minutes before transfer. Any questions about that? All right. So going on to our protocols, um, I put in both the chest pain and the STEMI protocol. So we're only going to be administering oxygen if the patient has SATs that are below 94%. We'll get a 12 lead, and our goal is to get that within 10 minutes based off of our KPIs. Aspirin 324 unless contraindicated. And if the patient's systolic blood pressure is less than 110, um, all right, let me rephrase that. If our patient's blood pressure supports potential vasodilation, such as their blood pressure is systolic blood pressure is greater than 110, then nitroglycerin can be considered. We'll want to repeat it every 3 to 5 minutes, up to 2 times, if we decide to continue it. And then if a patient is having evidence of a right-sided MI, so positive changes in V3, V4, we may want to be either cautious or withhold it. And then if a patient is on phosphodiesterase inhibitors in the last 48 hours, we do not give nitroglycerin. And vascular access should be obtained prior to giving nitroglycerin, but it's not a black and white decision maker on that. Pain can be managed with 1 mic per kg of fentanyl, can be given IV, IO, or IM, no more than 100, and can be redosed every 5 to 10 minutes. I would say that sometimes your patient develops hypotension with fentanyl, so I would be cautious about giving the full amount that they possibly can have, as opposed to redosing them to make them more comfortable. And then if the patient's hypotensive, you go into the shock protocol, but we're just going to skip over to the STEMI protocol. Patient has to have 1 millimeter or greater in at least 2 contiguous leads. It can't be a bundle branch or a paced rhythm unless there's concordance. And we want to notify the hospital as soon as possible for a concern for acute MI or STEMI. Give aspirin, nitro, and fentanyl as the chest pain protocol indicates. Send them to the most appropriate PCI capable hospitals. So the good news is that you have a couple choices now. Make sure that they're not on divert, and if none are available in the Clark County, then we'd be looking for the potential next closest, which might be Emmanuel, Providence, Portland Adventist, or Kaiser Sunnyside, or OHSU. If initial 12 leads negative, repeat every 3 to 5 minutes if symptoms persist. And then a reminder is that if the symptoms drastically change, if your patient's condition changes, to also can reconsider not only a 12 lead, but repeating vital signs. Yeah, I think that's what I have for you guys on that one. Anything else?
No, and I know we're fine tuning care, but I don't want it to get lost that, EMS care was a critical part of saving this patient's life.
Oh, absolutely. Absolutely. The only reason, I guess the only thing is I had was that I'm not sure with a GCS of 5 if the aspirin should have been given, but overall, they're like significant good that occurred because the patient had intervention with EMS first. And the reason why this even came to our attention was from the STEMI meetings.
Yeah. Dr. Gabois, Dr. Whitwer had a question about, was that patient discharged to a sniff?
I can't tell you that for sure. My assumption is yes, after 30 plus days in the hospital, but I don't know that for I didn't look to see. What I do know is that I looked to see that he's had multiple visits within the healthcare system since then. So like primary care, cardiology follow-up, I think I probably saw like 4. So he is capable of making it to his visits. But other than that, is that any other questions?
Nope, not that I see.
Alrighty. So the next case is, let me just see if the medic. Oh, I don't think the medic will be able to present her side. So next case is a 56-year-old female motor vehicle crash, single vehicle hitting a tree. The patient had sustained a crash and was complaining of chest pain, dizziness, and shortness of breath. When EMS made contact with her, she was alert, her airway was open, she was protecting. They documented that she was cyanotic, pale, and very diaphoretic. Vital signs were reported to occur and at the same time as patient contact. So heart rate of 42, blood pressure 103/82, respiratory rate of 26. The past medical history documented was cardiac condition. I'm not sure if the patient couldn't elaborate, and no meds were reported. She was the driver of a car that struck a tree, unknown speeds, no airbags. She was restrained and she was able to self extricate. EMS had documented that she was confused. She had told them she didn't lose consciousness, but there were no witnesses that could corroborate the story that she provided. She was complaining of some dizziness and shortness of breath preceding the crash, and she thought she had passed out prior to hitting the tree. And she had told EMS that she was supposed to get a pacemaker, but for whatever reason, they did not place one yet, and that was because she was having these syncopal episodes in the past.
And Dr. Gadbois, it looks like the medic is available. I think
Oh.
I'd welcome the chance to hear her point of view.
Yeah, absolutely. I was just looking at where I was corresponding with her. So, Ella, can you unmute? I'm not sure if anybody else on the call can help make sure that.
You're unmuted. I'm just not hearing your audio.
Yeah, Dr. Gadbois, we might have to keep going. There's no audio from Ella.
Alrighty, just looking to see if there's anything I can do to help her. I feel like it's trying to get there.
Of your video, just not audio yet.
She on a computer or is she on her phone?
Yeah, a video, just no audio. Okay. Okay. Dr. Gabor, go ahead and certainly if you have anything to add, go ahead and add it in the chat or something. Sorry, we're not able to hear you right now.
Yeah, let me just give her my number to see if she can call real quick and I can put her on speakerphone over here. Ella, check your message. I've got Ella on the line. Ella, you want to talk and see if the audio comes out okay?
Yeah, how is this working? Is this coming through?
How's that
Yeah,
for everybody else? Okay,
we can
perfect.
hear you.
Okay.
All right.
Okay, that sounds great.
Are you ready for me to switch to the next slide?
Yeah, the problem is I can't see the slide because if I'm by the computer, at the same time. It's going to echo.
Oh, okay. Well, let me help you out real quick.
Do you want to just walk us through the call and kind of tell
Yep.
us what it was like?
Yep, I can just take you through of what I remember real quick.
Hold on 1 second. Since you're on it, let me just help you out by just giving you a screenshot of it, and then I'll just send that to you. Thanks for you guys' patience here. All right, here's your screenshot, and hopefully you'll see it. Okay.
Okay. All right, here we go. Yeah. Okay, so basically we're second on scene. This was actually a really interesting case. Thanks for the opportunity to present it. When we got on scene, fire had been there for a bit. The patient was standing up, talking with fire, moving around voluntarily on her own volition. She, by the time we physically got over to her, she was sitting down on the curb, holding her head, holding her chest. And she was notably anxious. We threw a C-collar on her. No vitals have been taken quite yet. I think everybody was kind of just trying to figure out what happened. Her car was in, head on into a tree, kind of wrapped around it. Looked like it had been a high mechanism of injury. The patient kind of just was a little out of it, not really able to answer questions. It was very unclear if she was in kind of a mental shock or if she was altered. So once we got a set of vitals, we noted that it was abnormal, that she was hypotensive. Also, her pulse rate was 42, I think was the first pulse I palped on her was 42. She was in a state of hyper anxiety to the point where I would expect her to be at the least tachycardic, if not hypertensive as well. So the findings were very abnormal, which indicated that I really wanted to get an EKG on her. So we loaded her into the ambulance with the spinal precautions that we had. She was not able to tell us the story of what happened. She was just kind of coming across as confused. We'd ask her questions. She'd kind of just hang out there for a minute and be mumbly and then kind of be like, I don't know. And we're like, well, do you remember the accident? And she's like, I don't know. And so it was really, she was a poor historian in the beginning. She kept complaining of chest pain and head pain. It did look like she had been restrained, but she self-extricated, so we couldn't quite be sure. She did have, I think I remember her chest had abrasions, like it did look like a seatbelt sign on there.
Yeah.
And she had abrasions on her forehead. I don't think there was no bleeding or obvious deformities. So anyway, there was a little debate. The hot topic on scene was just whether or not to get a good 12 lead or just start going. I did feel like the 12 lead was really important in this case, so I just wanted to get that before we started rolling and push for that when we did get a 12 lead. I don't know if you have that, if you're able to pull it up.
Do. So the first 12 lead, just, the screen that she's looking at is going to be pretty small, so I'll just interpret it. Narrow complex, bradycardic, rate of 46. It looks like there's a P wave for every QRS, and the P is documented to be, they say where's PR? 0.20, so first degree heart block with some possibly ectopy, but maybe artifact, but ultimately it doesn't look to be AV dissociation or junctional.
Okay. So yes, I interpreted that exactly like you did, Dr. Gadwa. Very, very well done. We basically just saw bradycardia, and given the fact, I've seen a lot of patients with this number of their heart rate in the low 40s, and it wasn't concerning, but given her presentation, I was concerned about the bradycardia having been the possible cause of a syncope, which then led her to run into a tree head on. So I was kind of going with that differential diagnosis. We did have, there was a lot of talk on scene, arguing a little bit with the different diagnosis of a full trauma. So we were kind of going between those two. In the end, pacing was considered just because she was complaining of severe chest pain, shortness of breath. She was altered. Her blood pressure was on the low side. She was bradycardic, and she just had a traumatic event. So it was difficult to kind of go down both routes at the same time, just because we were pretty certain that she'd done some damage to her sternum and possibly her ribs as well. So she had good breath lung sounds on all of her quadrants. So I went ahead and gave her atropine just to kind of bump her heart rate up and see what that did. And just within seconds of the atropine, the patient started feeling better. She kind of came back mentally. She was like, you know what? I feel so much better. And I feel like I still have like really bad chest pain, but now it feels like it's my muscles and my bones rather than like my inside of my heart. And I was like, okay. So it was really cool to kind of see that that change in her blood pressure normalized. She did go back down, I think, a little bit. Her blood pressure went back down a little bit at one point. I'm not remembering it well, but
it went down a little bit, but I just pulled up the second EKG, and this was after the atropine, so you can see that her rate's no longer in the low 40s. It's 59 documented here, and again, narrow complex P waves for every QRS, and the PR prolongation is no longer present, so she doesn't meet the criteria for first degree anymore.
Okay, so yeah, it really seemed to fix her, and the most marked difference I saw was her mental status was coming back. She was no longer short of breath. We then followed her care up to kind of go towards the trauma side and gave her some fentanyl for pain, and she rode the rest of the way in with minimal complaints.
Yeah, and then also a third, the 212 leads, but as you can see for those following along online, she transports within less than 15 minutes of patient contact, did a lot of stuff in that time period, and still got to the patient to the hospital within, I do math horribly in my head, 22 minutes of from patient contact to arrival to the hospital. So really quite impressive given the complexity of the situation and the interventions performed for her. Thank you, Ella.
I actually have a question real quick.
Yeah.
When you do these case studies, I'm very curious to know if the initial point of contact is fire or is that AMR?
So if I have access to both, sometimes I don't. I go off of the first on scene. This one is based off of your arrival.
Okay.
Oh, and then did you guys end up doing a Pulsera? Because I didn't find one.
Yeah, well, that's too bad that you remembered to bring that up, because this is the one and only time I did not do a Pulsera.
No worries.
I had handed my phone to the fire guy and said, "Can you please enter these vitals and push alert?" And then he entered the vitals and didn't push alert. Not to blame it, but I'm blaming it.
Okay, no worries.
Yeah, we rolled into the hospital and realized it had never been sent. So I was a little sheepish coming in. But yeah, the doctor was really nice that I gave a report to. So.
Oh, that was me.
It was you. It was you.
Awesome. All right. Well, I will go forward here then. In regards to this patient, I thought that the differential diagnosis was really, really excellent, that they didn't, I think it'd be easy to be like, oh, car crash, chest pain, and there's abrasions, and to think that all of her complaints were related to her injury. The documentation about the complexity of the scene, as well as the complexity of the decision-making going through the patient's presentation, I thought was really good. And then, even the documentation that Ella had mentioned here just now about how she felt it was really important to get a 12 lead and get the best quality 12 lead prior to initiating transport, knowing that that can degrade with movement. I thought that the consideration for a trial of atropine, like as she just mentioned here, that we see patients in the heart rates in the 40s, and that's maybe where they live at, but given the context of how she looked and how she was acting, that I think it's totally appropriate to trial atropine. And she had this patient coming in as a yellow acuity. And I think ultimately we actually had upgraded when they arrived to a modified trauma. And I think that they would have been a modified trauma if the Pulsera had gone through. So at that point, trauma wasn't at bedside, but as you had just heard, that there was a little bit of a miscommunication about notifying the appropriate folks. It didn't harm the patient by any means. And then areas for improvement, I really don't have any. In the emergency room, she presented with a heart rate of 67. Her blood pressure was improved at 188/67. We didn't report a respiratory rate initially, so I don't really know. Sometimes that gets missed, despite all the hands that are available, and her SATs were 93%. She had reported that previously she had some lightheaded episodes and that she didn't meet the criteria for having a pacemaker at that time, and that she did report some nausea and she did admit to some marijuana use when I assessed her. Her workup was pretty extensive given the potential for significant mechanism injury. So she had a CT of her head, CT cervical spine, CTA of her head neck in the event that there may have been some type of neurological compromise to the patient having a single episode. And then she had a CT of her chest, abdomen, pelvis. She actually had suffered a subdural hemorrhage. She suffered sternal fractures, rib fractures. Um, so that was all related to her mechanism of injury. Her drug screen came back positive for marijuana and methamphetamines. And because of her complexity with her bradycardia leading to syncope, her bleed in her brain, and her injuries in regards to her sternal rib fractures, both are all our trauma docs, our neurosurgeon, and our cardiologist were consulted for her presentation. She was admitted for 6 days. And according to the documentation, she had a previous history of sinus pauses. She also had some bradycardia and AFib with RVR. Um, she had a pacemaker placed during her hospital encounter because of her syncopal episode leading to her motor vehicle crash. And in the notes that her previous presentations of like lightheadedness, they had told her that she shouldn't be driving, but she had chose to drove anyway. And as regards to her methamphetamine use, she had said it was recreational and that she wasn't having an ongoing problem with it, so wasn't interested in any type of resources. So, in this particular case, like a complex patient, multiple significant issues, both medical and trauma going on at the same time. I thought it'd be a good time to talk about syncope preceding trauma. And I think that, we think about that sometimes when we have like a single vehicle crash, but I think we should be asking ourselves that. And it's one of the reasons why when you guys bring in a fall, we ask, well, what caused the fall? Was it that you tripped and fell, got caught up, or whatever? Because it's a very different and very big workup when we find that there's a medical cause that preceded the trauma, especially if it's potentially syncope. So as a reminder, syncope is a brief loss of consciousness due to decrease in blood flow to the brain that's transient, usually, because if it's persistent, they usually are unresponsive, like continued unresponsive or and go into cardiac arrest. And in one particular study that looked at the population data, it said that approximately 42% of people by the age of 70 have suffered a syncopal episode. Then cardiac syncope increases your risk of death compared to no syncope 2 times. And cardiac syncope, this chart here on the right-hand side kind of lets you kind of think about the causes of cardiac syncope. And it kind of makes sense when you're thinking about, oh, these are the reasons. So obstructive structural heart disease, such as aortic stenosis, HOCM, those are, our pediatric or young adults that have been, doing something active and all of a sudden go into cardiac arrest. Cardiac masses, pericardial disease or tamponade, problems with their prosthesis for their valve, congenital coronary artery abnormalities. As for like my personal experience, my brother passed away at age 15 from a coronary artery abnormality that he was born with and undiagnosed. Any kind of arrhythmias, like tachy and bradyarrhythmias, and then problems with obstructive etiology, such as like PE, aortic dissection, and pulmonary hypertension. So if there's one of these causes, cardiac syncope, it increases your risk of death 2 times compared to having no syncopal episode. And as you can tell, these are major causes for a person to have a syncopal episode. An EKG can diagnose the cause of syncope in about 50% of the patients. So getting a 12 lead is hugely important, and getting an early 12 lead can make a big difference in trying to resuscitate a patient that may have one of these, problems like cardiac syncope, and you're also having concomitant management of trauma, that there may be some decisions that change regarding treatment, as the case with Ella, where she tried atropine, which wouldn't be part of our trauma resuscitation algorithm. And then patient history is really important if the patient is a good historian, but collateral information is also very relevant, as the patient's perception of what happened may not actually be reality. And then anybody, I guess I'll go through the Southwest region protocols and then check in if anybody has any questions or want any comments. But so syncope and bradycardia were the two protocols that I pulled up for this case. So syncope, loss of consciousness, and postural tone usually resolving without any type of intervention. Some people call it fallout or fainting. I'm going to go down to treatment. So you want to make sure that you're looking for neurological issues such as a stroke or altered mental status, which this patient had, which may make you go down the different pathways. Management should be directed, discovering the physical exam or additional examination that may include management of cardiac arrhythmias, cardiac ischemia, hemorrhage, shock, manage the airway, give oxygen if necessary, evaluate for hemorrhage and treat shock. IV access is important. Consider a fluid bolus, which Ella and her team did a cautious IV fluid bolus at 250. Place them on the monitor, get a 12 lead, and manage any arrhythmias. And then as for bradycardia, get them on the 12 lead, continue monitoring the patient. If they have signs of poor perfusion, such as altered mental status, signs of shock from like cardiogenic causes, or hypotension, and their bradycardia, could be the etiology. A trial of atropine is appropriate. And if no response to atropine and you feel the patient is still in quite duress, you can try epinephrine infusion or pacing them. And I think she mentioned it when she talked about her case. She also had placed the defib pads on within 4 minutes of their arrival. So that's all I have for this case. Great job, Ella and your team. Anybody have anything else to add?
Thank you very much for presenting, and I appreciate the way you thought through that. And then just a couple clinical points about syncope. Syncope from seated or supine is a lot higher risk than syncope from standing, because that means that they didn't even have enough perfusion to get to the brain when seated or when supine. And then another presentation that's really high risk is exertional syncope, because typically you should be increasing your cardiac output with exertion. And if something happens with exertion, where you then pass out, that tends to be high risk. So those are high risk presentations of syncope. But great job, and thanks for presenting.
Yeah, thank you, Ella. All right, so moving on to our last case, case 4. Another motor vehicle crash, single vehicle to a pole, so a little different. EMS gets dispatched to motor vehicle crash. The patient is complaining of respiratory distress. She's a 40-year-old female. She's awake. Her airway's open. She's protecting. Her breath sounds are clear to auscultation, but she's very anxious, and there's no signs of active bleeding. I want to say that she self-extricated, and it's documented that she had laid herself down on the sidewalk. At 7 minutes after patient contact, they document a heart rate of 36, no blood pressure is recorded, respiratory rate of 20, SATs of 95%, and she's approximately 136 kilos. No past medical histories obtainable, nor is any medications. And the history that EMS documents is that it was a single vehicle crash to a pole, unknown speeds, airbags did deploy, she extricated herself, and she was lying on the ground. This is an early morning call at 5:26. At 5:32, they placed her on 4 liters nasal cannula. They document that her spine was cleared, although a lot of the documentation is that she was very confused and uncooperative, so it's something to consider. At 5:35, they get another set of vital signs. Her heart rate went from 36 to 126. They documented blood pressure 101/61, respiration 20, and SATs of 100%. They place an IV. Because of her combative nature and difficult to redirect, they put her in restraints. Just a Velcro, from what I gather, no chemical, based off of the procedure chart, and they initiate transport approximately 21 minutes after patient contact. Shortly after they initiate transport, they start to bag her. They document that she becomes more obtunded, and then she becomes bradycardic, but it's possible that I may have missed the vital signs that they had reported, but the documentation was that she became more bradycardic, obtunded, and then CPR was initiated after patient transport, approximately 11 minutes into transport. They placed an IO. They gave her 400 mLs. They placed an iGel. They gave her epi ×3 and placed another IO and arrived to the hospital 20 some minutes after transport initiated, and 12 minutes after CPR was initiated. They put in Pulsera MVA into a pull, significant driver side damage with airbag deployment. Patient's alert but uncooperative, self-extricated, recorded the vital signs, not the bradycardia, but the heart rate of 124, and a GCS of 13, and blood glucose of 208. And then, so they tell us the vital signs at 5:49, and then they document that she arrested at 6:02 in the morning, en route. So the good serial vital signs, IV access or IO access, Pulsar notification, and a change in her status, and then areas for improvement. Just reading this case, I felt a little uncomfortable about how her spine was cleared. The scene time was, in retrospect, longer than our full trauma times should be. And then trauma arrest management, remembering our HAT resuscitation. So in the emergency room, her pupils are fixed and dilated. There was noted that she had crepitus to her chest. The trauma surgeon was at bedside. He performed a resuscitative thoracotomy on the left side after 5-minute delay of getting the equipment that wasn't available. I don't really know if that's because of the new ER or whatnot. The ER doc placed a right chest tube, and the trauma surgeon documented in his note that there was a 15-minute delay because CPR was ongoing for 15 minutes longer because there was a delay in transport due to active crime scene. So it wasn't documented elsewhere, so I'm not really sure about that information. And then she was deemed non-survivable from her injuries. She didn't go to the operating room, and they pronounced her at 6:23 in the morning. So I don't quite remember why this case came across my desk, but I think that it was probably in regards to some trauma resuscitation discussions we've had in the past recently. But death in the field, cops looking at unwitnessed traumatic arrest or even trauma arrests that are witnessed. But anyways, it's what it says here. Unwitnessed traumatic arrest is almost uniformly fatal, while EMS witnessed arrest due to severe hypovolemia, hypoxia, or tension pneumo may respond to resuscitation, I mean. So witness arrests, we're giving them IV fluids. If you remember, she got 400. We should be really actively trying to give her fluids, although ultimately the right fluid for her to be blood, and the right treatment would be surgery to fix whatever was bleeding. Airway oxygenation, ensure patency, they placed an iGel, and then tension pneumo, perform bilateral chest needle decompressions if indicated. I think that she's complaining of shortness of breath. She rested, and I don't know if during the CPR her crepitus was notable or if it preceded the CPR, but I think that placing bilateral needle decompressions in a witnessed arrest in a young person, relatively 40 years young, is warranted to needle her bilaterally in any effort to try to resuscitate her and get her pulses back. Traumatic patients who are pulseless and apneic on EMS arrival considered dead in the field unless they are extenuating circumstances. She wasn't on arrival. She arrested en route. And for patients found in VFib or pulseless VTAC on EMS arrival, you should suspect a medical etiology and treat it as a potential medical. And patients who deteriorate to PEA or assisted on scene begin CPR while performing HAT resuscitation. And if ROSC is obtainable, transport to trauma center. If ROSC is not achievable and you haven't initiated transport, if it's less than 10 minutes from witnessed arrest to trauma center for blunt trauma or less than 15 minutes for isolated penetrating trauma, initiate transport. And if the above criteria is not met, declare death. And if the transport's initiated, continue treatment and transport until care is received to the hospital. Anybody have any other questions or concerns or points they want to bring up about this one? If not, then thanks for your time. I usually go over reviews of everything, but I put my dog to sleep for final sleep last night, and I just don't have the energy to review that. But thank you for your attention, and as always, feel free to reach out to the MPD's office if you have any questions. Thanks.
Thanks, Dr. Gabois.
Thank you for presenting. We appreciate it. We're sorry for your loss.
Thanks. I appreciate it.